Welcome to Healthmark's 7 Days of CEs for SPD Week 2024. This is John Whalen, and this program is covering AAMI TIR99 and best practices for processing ultrasound probes. So ultrasound probes are very prevalent in healthcare. They may not be the most complex reusable medical device, but the wide variety of clinical applications and the variability of training for staff who process them do pose potential risk. Best practice considerations for processing endocavitary ultrasound probes and TE probes will be presented here, with AAMI's Technical Information Report, or TIR 99, highlighted as a source of best practice guidance. What you see here is an example list of common clinical sites where ultrasound probes exist. It can include a wide range, as you see, from a hospital-based emergency department to an off-site family practice clinic miles away. Depending on the individual organization, some of these may not be included. For others, more is included. Let's use this list to make an example. An important point here is that the majority of these are clinics. The realization here is that depending on the health system, it's not uncommon for some or all of these sites to manage the processing for these devices themselves. They don't necessarily route to a centralized processing area like an SPD. So within any given health system, this poses potential risk due to lack of standardization and consolidation. What are common weak points and risk? As with any process, quality is harder to manage and standardize when there are multiples. Having multiple sites, multiple staff involved, multiple devices to be processed, multiple processing methods, all make this risk prone. Just think about the not uncommon scenarios that have and do exist for processing reusable items from a clinic. Think of the MA or the tech who is hired and trained predominantly to room patients, assist caregivers, and provide supporting services, also having device processing added to their plate. They never received extensive device processing training in their MA program. Think about the coincidental demands made on them and the very real possibility that shortcuts may be taken intentionally or unintentionally to just keep up. Think of the labor and delivery triage area at a large teaching hospital where 24/7 vaginal ultrasound probes may be processed by a tech or a nurse or a resident physician. So where do we start, and what should best practices be based on? Best practices should be based on manufacturer's instructions for use, or IFUs, standards and guidelines, and your institution's written policies. Your processing policy should always reference following IFUs and follow guidance from standards and guidelines. Let's briefly reference following IFUs. In a healthcare setting, there exists the distinct obligation to not only have and keep IFUs, but to know the content and to follow the prescribed IFU steps in actual practice. This is where a lot of problems arise, as well as citations on surveys, not knowing or following the IFU. Remember too, it's not just the device IFU, for example, the probe that you're processing, but also the IFUs for any related processes, including automated equipment and chemistries like detergents, high-level disinfectants, or sterilants. There currently exists considerable variation and lack of standardization in IFU content for ultrasound probes. For example, here you see a crosswalk that I developed at our health system a few years back as we were developing system policies for ultrasound probe processing. We wanted to see where things were at and where we could standardize. When you compare direction for bedside pre-cleaning, manual cleaning, and storage, it can be very different from one manufacturer to the next. We stated that best practices should also be based on standards and guidelines. Historically in the US, formal direct guidance for processing of ultrasound probes came from really only a few professional sources, namely the CDC and the American Institute of Ultrasound in Medicine, AIUM. Indirectly, guidance may have come to individual sites from accreditation surveyors, though it was much more common that flexible endoscopes garnered the most attention during such surveys. It's because of this variability in IFUs, the limited formal guidance from professional organizations, and an increasing number of reports that processing was not consistently performed correctly, that AAMI made the decision to author a Technical Information Report, or TIR, related to processing of ultrasound probes and dilators. The same AAMI work group that authored ST91 was responsible for the development of this publication. A TIR is not a standard. It's the beginning of formal best practice guidance recommendations. It's possible it could develop into a future standard. The focus of TIR99 is to offer guidance for processing ultrasound probes, to include intraoperative, transesophageal, transrectal, transvaginal, ophthalmic, and surface probes. Additionally, this TIR addresses vaginal, esophageal, rectal, cervical, tracheal, nasal, and urethral dilators. The focus of this presentation here, though, is on probes. As is the case for AAMI standards documents, predominant content focuses on each step of processing, from patient bedside through processing to storage. And like the format used for ST91, additional content includes recommended processing information for device manufacturers to provide for those who clinically use, as well as those who process these devices. Also, the use of probe covers, the use of gel and accessories, the physical design of processing areas, personnel qualifications, education, training, and competency verification, documentation and traceability, and quality control. Let's highlight a few sections. When it comes to training and competencies, like any other reusable device processing, the guidance here is for minimally annual renewals of processing competency for anyone involved, as well as when processes change, devices or equipment change. That might seem obvious and commonplace to those who work in centralized processing areas, but annual competency renewals for processing need to occur regardless of where ultrasound probe processing takes place. A helpful table provides example clinical procedures involving probes and dilators, and categories of how they would then fall into Spaulding's scheme as critical, semi-critical, or non-critical devices. Like flexible endoscopes, it's known that not all probes that exist today have IFU support for sterilization. So, liquid chemical sterilization or high-level disinfection would then be indicated for critical and semi-critical applications. As a processing professional, you may not know whether a probe cover was used during the actual clinical procedure, but it actually doesn't matter because the probe is processed based on the contact site in the human body. For example, intact skin versus mucous membranes or sterile tissue. According to the Spaulding's classification system, we process reusable medical devices based on the risk for infection, commonly making decisions on how the device was just used clinically. When it comes to determining the appropriate level of processing for ultrasound probes, though, it's important to focus not just on how it was used prior, but on how it may be used in the next procedure. For example, a surface ultrasound probe may have only contacted intact skin, which would then allow for surface disinfection as a correct level of processing post-procedure. However, it could be used next intraoperatively or at the bedside in intensive care. where it could contact sterile tissue or blood, in which case it should then be sterilized before use if the IFU allows sterilization, or possibly high-level disinfected then used with a sterile cover. It's critical then within a health system to have multidisciplinary discussions proactively to determine standard processes, to limit assumptions, and limit patient risk for improperly processed devices. Unique to the processing of certain ultrasound probes is that the entire device may not be processed to the same level. Think of vaginal or rectal ultrasound probes as well as TEE probes, as you see here on the slide. The actual probe section, the shaft or the body, is subjected to high-level disinfection, but the attached cord and electrical component can't be submerged in solution, so they're surface disinfected. Again, here it's useful to have multidisciplinary reviews of processes, from clinical use through processing to storage, to ensure that the component parts are processed correctly and separated during transports. Like other AAMI standards, manual high-level disinfection is not recommended for standard processing due to the human variability and inconsistency in manual processing. Manual processing still needs to exist as a backup, and staff still need then to have related training and competencies. Whether manual or automated, all steps before and after high-level disinfection are still required. For example, point-of-use treatment at the bedside prior and drying after. Automated options for processing ultrasound probes includes dedicated automated cleaning and high-level disinfection systems, examples of which you see here. Starting at the left, the Trophon. It's a 7-minute high-level disinfection cycle with sonicated vaporized hydrogen peroxide. Unfortunately, it won't accommodate all models of rectal ultrasound probes, though. In the middle, we have the Ethos. It's an automated cleaner disinfector. It's a 3-minute cycle with proprietary peracetic acid-based cleaning disinfectant solution called Aquacide. On the right, we have the Astra VR. It's automated high-level disinfection, an open platform, so you could use OPA or Recert. It can do 2 probes at one time, and it has a 12 to 16-minute cycle depending on high-level disinfection. For TEE probes, there are also automated cleaning and high-level disinfection systems. On the left, we have the Astra TEE. It's automated high-level disinfection, again, an open platform, so you could use OPA or Recert, a 10 to 16-minute cycle. It can do 2 probes at one time. Next, we have the TD100, automated high-level disinfection, 5-minute cycle time, single-use proprietary high-level disinfectant of OPA or glutaraldehyde. Next, we have the TD200, which is also automated high-level disinfection, a 3-minute cycle time with single-use proprietary peracetic acid. And then on the far right, we have the TEE Clean, which is automated cleaning and high-level disinfection, proprietary enzymatic detergent, and like the TD100, a 5-minute cycle time. So you can see for both ultrasound probes and TE probes with the automated equipment, there's variation whether or not it does cleaning and high-level disinfection or just high-level disinfection, the cycle time, the chemistries used, and whether it's 1 or 2 devices at a time. Remember too that for automated cleaning and disinfection for both ultrasound probes and TE probes, some models of automated endoscope reprocessors or AERs can accommodate these. They have attachments. With that, within a given health system, it's useful to keep this in mind when deciding what departments are options for processing, as well as where the backup options exist when processes at an individual department are interrupted or not available. When it comes to documentation and traceability, AAMI TIR99 repeats what we've heard through other standards and guidelines. All processing needs to be documented. It can be done on paper or electronically. The retrievable information that's required is the identification of who processed the device, the identification of the device, in this case the probe, the date and time of processing, and the indication that the processing cycle was completed or that it passed. For probes and dilators, they need to be traced to an individual patient, and there needs to be labeling prior to storage. Remember, post high-level disinfection, a device looks physically the same as it did post-procedure after point-of-use treatment. So we need to label the device to make sure that anyone can tell whether it's been through processing or not. When it comes to storage, probes should be dry prior to storage to limit contamination in the environment. From TIR 99, probes post high-level disinfection are recommended to have additional protection, for example, cabinet storage or a probe cover. Probes should not be stored, though, with gel or gel covers in place. Those are the covers that are used for the procedure itself. A standardized process should exist for visually communicating the status of the probe, as we just mentioned. For example, a post-processing tag or label indicating high-level disinfection would exist to indicate the patient-ready status for the probe. When such a visual cue is absent, the assumption should be that processing is required. In considering TEE probes, even though many approach these just like they would a flexible endoscope, remember, they are not flexible endoscopes. They are not channeled. The entire device cannot be submerged in solution. Where we routinely fluid leak test flexible endoscopes for TEE probes, they require electrical leakage testing each time they're processed. Unlike flexible endoscopes, no one has prescribed a standard storage expiration or hang time. Facilities are recommended to perform risk assessments related to storage and determine when devices need to be processed if they haven't been used within a certain period of time. Just like flexible endoscopes, TEE probes should have visual cues on the device itself to identify when they have been processed. Best practice storage for TEE probes is in hanging cabinets with active air filtration. In summary, some key takeaways for both ultrasound probes and TEE probes. They exist in varied clinical locations throughout any given health system, and there's varied processing that takes place depending on the department or the available means. IFUs for probes are varied. The content is varied from one manufacturer to the next. Automated processing is recommended, with manual high-level disinfection as a backup only. These devices should have post-processing visual cues. They should be stored protected. Remember, too, we need to consider when it comes to probes, how was it just used clinically, but how may it also be used in the next procedure? And within a given health system, we need to have risk assessments and standardized processes to help determine what the best approach is for having these be patient-ready and safe. TIR 99 is an option to help provide best practice guidance. For more information, definitely consider having accessible copies of TIR 99 within your department or your health system. Additionally, I'll offer a few related CER lessons I authored related to ultrasound probes. These that you see here were published in Process Magazine November-December 2020 and January-February 2021. The objectives for these: identify the different types of ultrasound probes in their varied clinical practice settings, review the existing guidelines and standards for ultrasound probe processing, outline the common steps in processing these devices, and discuss existing challenges limiting standardization of practices for processing of ultrasound probes. Also, for the May-June issue of Process this year, I presented AAMI TIR99 as a CER lesson. That article identifies areas of concentration within the report, highlights important practice considerations, and describes content for related quality assurance and policies, procedures to guide practices. Here's the bibliography for this program today. Thank you very much for being part of this. I wish you constant vigilance and success in your work.